Hello, my name is Tausan Rashdan. I'm a thoracic medical oncologist. I practice at UT Southwestern Medical Center, and this presentation today is about toxicities related to checkpoint inhibitors in non-small cell lung cancer. The points that I'm going to discuss in this presentation include the incidence of toxicity with checkpoint inhibitors when used in lung cancer, patterns of immune-related adverse events. We're going to talk about general rule for management of immune-related adverse events. We're going to talk about specific management of specific immune-related adverse events based on the system that's involved. We're going to talk about pulmonary toxicity or pneumonitis, and then we're going to have some take-home points. The incidence of toxicity with checkpoint inhibitors. The most common checkpoint inhibitors that are currently used in lung cancer treatment include PD-1 inhibitors, and the ones that are available right now are nivolumab and pembrolizumab. We have PD-L1 inhibitors with atezolizumab, avelumab, and durvalumab. We have CTLA-4 inhibitors with ipilimumab and tremelimumab. Immune-related adverse events are significantly less frequent with anti-PD-1 and anti-PD-L1 antibodies compared with anti-CTLA-4. It's about 10% with anti-PD-1 and anti-PD-L1 and up to 30% with anti-CTLA-4. The toxicities are increased in patients who are treated with combinations of immunotherapies, such as regimens such as nivolumab plus ipilimumab, and also concurrent or prior or recent treatment with radiation. That also increases the risk for immune-related adverse events. There's really no proven correlation between the incidence of immune-related adverse events and the tumor efficacy of immunotherapy. There's no good predictive biomarker for immune-related toxicities, unfortunately. Patterns of immune-related adverse events. The most common immune-related adverse events in lung cancer include dermatologic or mucosal toxicity. We also see diarrhea or colitis. We can see hepatotoxicity. Pneumonitis is very important in lung cancer. And we can also see endocrinopathies that include hypothyroidism, hypophysitis, adrenal insufficiency, or type 1 diabetes. The skin toxicities tend to occur earlier compared with other toxicities. That is followed by the GI and pulmonary toxicities and lab abnormalities. However, really in general, any of these toxicities might occur at any point during treatment. The toxicities can affect more than one organ system, and it can range from asymptomatic to severe or life-threatening. The general rule for management for immune-related adverse events, and this is really taken from the guidelines that we have from the American Society of Clinical Oncology and the Society of Immunotherapy of Cancer Toxicity Management Working Group. There's two main rules that we have to follow when treating immune-related adverse events. The first rule is holding or interruption of the checkpoint inhibitor. The second rule is the use of corticosteroid immunosuppression. And also the treatment of the immune-related adverse events is based on the severity of the observed toxicity. For patients with grade 2 or moderate toxicities, treatment with checkpoint inhibitors should be withheld. Also, you can administer corticosteroids with prednisone of 0.5 milligrams per kilogram per day or equivalent. For patients who have higher grade toxicity, grade 3 or 4, or severe life-threatening toxicities, treatment with checkpoint inhibitors should be permanently discontinued, and a high dose of corticosteroids with prednisone of 1 or 2 milligrams per kilogram per day should be given. Also, another important note is that tapering of the corticosteroids should be done slowly, and it should only start when symptoms start to subside to grade 1 or less. Corticosteroids then can be gradually tapered over at least 1 month. If symptoms do not improve after administering a high dose of corticosteroids, you can certainly consider giving another type of immunosuppression with infliximab, 5 milligrams per kilogram. If symptoms persist after the first infliximab dose, you can give a second dose of infliximab, which is another 5 milligrams per kilogram, and that can be repeated 2 weeks after the initial dose. And now we're going to talk about the specific systems that can be affected with the immune-related adverse events. For example, the skin immune-related adverse events for grade 1 or 2 skin immune-related adverse events, we can use topical corticosteroids. We can use oral antipyretics. For grade 3 and 4, we really have to use oral steroids. If we have diarrhea or colitis, for grade 1, we can use budesonide, which is an oral corticosteroid that does not get absorbed by the GI system. For grade 2, we really always have to do a colonoscopy and then treat with steroids if there's colitis. You also should consider checking for CMV as that can give similar symptoms to the immune-related adverse events affecting the GI tract. For grade 3 or 4, which is defined as 7 or more stools per day, we really need to consider permanently discontinued checkpoint inhibitors and administering high dose of steroids. And if there's no response, we can give infliximab. For hepatotoxicity, if it's grade 2, which is defined as liver enzymes that are more than 2.5 times normal, or total bilirubin of more than 1.5 times normal, treatment with checkpoint inhibitors should be withheld. And then after that, you can monitor the liver enzymes and re-challenge with checkpoint inhibitors when the numbers are back to normal. However, for grade 3 or 4, where liver enzymes are more than 5 times upper limit of normal, or the total bilirubin is more than 3 times normal, treatment should really be permanently discontinued. Oral corticosteroids should be also administered. Here I'm going to talk about some special notes about endocrinopathies management when associated with the immunotherapies. What's special about endocrinopathies is that once the damage is done to the gland, it's really oftentimes irreversible. There are situations that you can catch the patient early and in that situation administering high dose of corticosteroid, which is 1 milligram per kilogram of prednisone daily, may result in reversal of the inflammatory process in some situations. However, that only rarely happens, and practically we really just have to supplement the hormone that is typically secreted by that gland. For example, for hypothyroidism, we just give levothyroxine. For hypophysitis, we give levothyroxine and hydrocortisone if needed. For type 1 diabetes, we give insulin. And you can almost always re-challenge with checkpoint inhibitors in this situation. You just supplement with the hormone that's needed and re-challenge and put the patient back on checkpoint inhibitors, especially if the patient is benefiting clinically from checkpoint inhibitors. Now we're going to talk about pulmonary toxicity or pneumonitis management. Really the same rule of thumb applies here, holding the offending agent, which is the checkpoint inhibitor, and starting steroids with prednisone of 1 milligram per kilogram daily. What's important to note here is that management should be started immediately without waiting for a pathologic confirmation of pneumonitis, which can be done through EBUS and can take some time to be accomplished. Also, tapering of the steroids should be done very slowly by 10 milligrams per week, and that should begin after improvement of the symptoms, the baseline. With this really long course of steroids, please remember to put the patients on PCP prophylaxis if needed. In cases that are refractory to steroids, additional immunosuppressive agents might be considered, such as infliximab and cyclophosphamide. Now, some take-home points. The incidence of immune-related adverse events is increased in patients being treated with CTLA-4 inhibitors, and also in patients who are getting combinations of immunotherapies or patients who had recent radiation. Immune-related adverse events are unpredictable and potentially can be life-threatening. The mainstay management of immune-related adverse events is to withhold the offending agent and to administer corticosteroids. After immune-related adverse events that are associated with endocrinopathies, oftentimes you can supplement with a specific hormone of the affected gland and continue treatment with checkpoint inhibitors. Pulmonary toxicities can be life-threatening, and treatment should begin immediately with corticosteroids and holding the checkpoint inhibitor. Thank you so much for your attention.